Welcome to the Reflection Room. We are so excited about our conversation today. We have a name that's going to sound very familiar to you as he attended an episode not too long ago. I was talking about what he does, his history, his background, and his focus recently on TMS services and what it offers, the benefits of it, and the ways that patients can receive that treatment. He is back today to talk about psychopharmacology, another passion of his and a service that his offices offer. So can we welcome Dr. Griffith? How are you?
I'm doing very well. It's great to be here. I must say that you all run a great podcast. I think it's very professional, and I appreciate how you ask questions and allow for discussion. It's an amazing podcast. Thank you.
Thank you so much. Yeah, we're so happy to have you back. We're really excited about today's conversation. And I think this is something that people might feel like they're more familiar with, but I'm sure there's so much more information underneath that they really would love to learn and to receive additional knowledge and expertise from you on today. So we're excited. So I guess let's start out with, I'll start out with a simple question and then we'll kind of go from there. But what is it specifically about psychopharmacology that led you to want to come back and talk about this topic today? What is it about that you would like to share with our audience?
Well, being a psychiatrist and being a medical doctor, if approach it properly, I'm like the software architect, a developer within helping a person with mental health issues. I have to understand what's going on, and I have to help them understand what's going on. And there's an entire treatment plan involved. And being a medical doctor, I have to rule out, like thyroid problems or sleep apnea, things like that. And then within the treatment plan, I'll often refer much of the treatment to other mental health practitioners like yourselves. So I'm a big believer in psychotherapy and counseling. And oftentimes I'll tell a patient, a brand new patient to me, say, well, I understand your story, and I think the starting point is to begin with counseling. You're under a lot of stress. There might be ways to navigate your way through stress, and we don't even need to use medication. But so often, a psychiatrist gets referrals of patients, for instance, with severe depression. They've seen a psychologist, a social worker, licensed mental health counselor in that field. Maybe they've also seen a family doctor who's prescribed kind of a simplistic antidepressant approach, let's just say Lexapro or Prozac, that doesn't work. So it's my responsibility to get a deeper understanding of how to provide medication or some type of biological treatment to help this person get through their depression. And my practice is oriented much more so towards mood disorders, anxiety disorders, and ADD, ADHD, attention deficit disorder, and attention deficit and hyperactivity disorder. So I'm very experienced with those types of medicines. But you have to get a really deep understanding of how much work that patient still needs to do in counseling, because I can prescribe the absolute best medication for a patient for their psychiatric symptoms of depression, for instance, but maybe they live in a Jerry Springer world. They expose themselves to stress. And so I will insist upon psychotherapy. And because the psychotherapy part is the software and the medication part and TMS is the hardware solution. And we're all like computer systems. We're not just software. We also have hardware and vice versa. So when it comes to psychopharmacology, which is the use of psychiatric meds to help patients recover from their symptoms, there are so many different options. And with those options, the medications will work on different neurotransmitter systems. For depression, for instance, I call them the 3 flavors of ice cream: serotonin, norepinephrine, and dopamine. And clinically, I had to train myself to get an understanding before ever writing a prescription for depression for a patient. Are there symptoms? Do they sound like they're more serotonin related or more dopamine related? And those are 2 ends of the spectrum. Norepinephrine is in the middle. And not only to help symptoms, but then you've got side effect issues of medication. And I think the real art of psychopharmacology is to basically not only help the symptoms improve, but to minimize side effects. So I have a lot of passion for psychopharmacology, but I have a lot of passion for what you guys do for counseling because we need to work together as a team to
Yeah.
help our patients become champions. That's what it's all about.
That, and I love how you
Yeah.
said the art of psychopharmacology. This is something Hannah's probably heard me say multiple times just over the years, but there is also an art to counseling. You know, there's the clinical aspect or the knowledge, the information, and then I always say there's this art form to what we do as well. And I think that's the individualistic aspect of like our jobs. You know, we learn like the book knowledge, which helps us like broadly speaking be able to work with our clients or patients and to treat them and really understand what might be in front of us. But then there's the art form where you really need to get to know your patient on an individual level in order to be able to create what you mentioned earlier, Dr. Griffith, which is like an individualized treatment plan. And so I love hearing you talk about that. I don't know if you've ever heard, you probably have. There's it's a completely false stereotype that exists out there where oftentimes, you know, clients might say, but is it worth going? I'm only going to be in their office for 5 minutes or talking to the doctor for 10 minutes. And so it's so great, I think, for people to hear someone in this field to talk about like the attention and the focus that they really provide their patients on an individualistic level. So I'm so glad that you shared that.
Right. Yes.
Yeah, especially getting to hear the passion behind it too. It's not just a job. It's like something that you deeply care about and spend your time learning. So I think that makes clients or patients feel a lot better too about going. So yeah.
It does. And it's interesting because there are lots of psychiatrists out there who are pure psychopharmacologists. And in my opinion, they don't have a clue about psychotherapy. They don't have a clue about the different theories and approaches of psychotherapy. And when I trained at the Cleveland Clinic, I was able to become the chief editor of a crash course, and we wrote a book for incoming psychiatry residents, like everything you need to know to get started. And I really dove into the various theories of psychotherapy and group therapy and couples therapy, etc. And I realized, gosh, it's so fascinating to do that. And so many psychiatrists, I think, these days in their training, they don't get that type of exposure to psychotherapy. And so here's your Prozac. I'll see you in 3 months, and it's a 5-minute visit. And what I do with my medication follow-up visits, I have the patient fill out a form before they actually meet with me. So it basically asks all the symptoms. The patient is answering these questions before they even see me, what symptoms they're having and how severe are the symptoms. Before I even sit down and begin talking with the patient, I basically have an idea how their symptoms are that I'm trying to treat with medication. And I'll spend 90% of the medication visit time talking about how's home life, how's your job, how's your family doing, you know, what's happening with your finances. So it's kind of like psychotherapy flyby. And then I write the story of how these things are going. So the next time I meet with them, it's like, oh my gosh, how's your grandfather? He had a stroke. You went up to see him. Is he doing okay? So it's really psychopharmacology should be integrated with the entire person holistically, and what's happening internally within that person, also what's happening in their environment. And that helps explain, oh my God, you know what? We don't need to add another medication. You need to become assertive with your sister and not be victimized by her. And I think if you do that, your current dose of the antidepressant is going to be adequate. Well, that's huge, rather than exposing them to more medication at a higher dose.
I love that. I actually was having a conversation yesterday with a group of ladies about this exact topic. So I'm a licensed mental health counselor, but I'm also a sociologist. So like I love hearing what you were just saying, Dr. Griffith, how oftentimes I think sometimes people within our field, they have these blinders on unintentionally to like other factors that could be influencing our clients and our patients. And I read an article the other day where it said, I wish therapists would become a little bit more knowledgeable on like their clients' social well well-being. And so I love hearing what you're saying, which is like there's so many different factors, and it might not be a change in the medication that's needed, but it might be something within their environment, or maybe there's a larger societal issue that they're really concerned about and worried about that a medication may not necessarily impact at a great level, but it's worth them going and speaking to their therapist about it, or processing with maybe a loved one or something, or joining some kind of support group or community. So I'm really happy to hear that that's something that that you take into consideration when you're treating your patients.
Yeah, and a metaphor to this is I can prescribe a medication and it's like, here's a fish. Or I can say, go do this assertiveness with that person who you live with. And that's like teaching them to fish for a lifetime. So,
Yeah.
that's very gratifying. So I guess what I'm saying is that some of the intrinsic beauty of psychopharmacology is the non-psychopharmacological things that a psychiatrist should do.
Mm-hmm.
Yeah.
Yeah.
Well, actually, on the flip side of that, sometimes, I'll have a client for an extended period of time and there's no progress. And maybe it could be a chemical issue. So I refer them to you. But what if that's their first time trying medication, or they have some concerns about trying medication? How do you go about that situation?
So this is a case where they haven't seen a Hannah
Like,
or a Natalie.
well, yeah,
Or they have.
yeah, they have been going to therapy for a long time,
Okay,
but they
okay,
haven't wanted to try medication, but maybe that is necessary.
okay. So let's assume that seeing the psychotherapist has been helpful. So it has helped them become grounded, but there's still residual symptoms, whether it's anxiety, depression, that even Sigmund Freud couldn't fix. Okay. Then that's where symptoms often are biological or genetic or organic from a thyroid problem, or they're just so severe that you could talk for infinity and they just can't turn themselves around. So yes, and that is often the case where a medication will be very helpful to that patient for the biological thing. And let me tell you how I see patients. Some patients are under so much stress that they burn out their stress response. It's day after day, week after week, month after month, year after year of being in a very chaotic, stressful environment. And some of those things that are happening in their environment, they can't change. It's out of their control. It just is what it is. And
Mm-hmm.
so, when patients burn out their stress response, that's when the biological symptoms of a chemical imbalance really set in. That's where their serotonin system is burnout. Their norepinephrine system is burnout. It's depleted. The dopamine system is burnout. Those are the mood-related neurotransmitter systems in the brain, the three flavors of ice cream. So they're fighting and dancing as fast as they can, but there's just so much stress they've burned out their biological apparatus. Adding in a medication can help restart that mood circuitry biology. They can have a better outlook. They have more energy, more motivation, more hope, more optimism, better self-esteem. And so sometimes the medication addition provides that magical touch. Then they come back after a week or two or a month to see you, and you're like, oh, you're doing a lot better. What's different? Oh, well, I saw Dr. So-and-so, and now I'm taking Lexapro 10 milligrams per day. So, yeah, that's true. Very true. And let me add that there are some disorders that even Sigmund Freud can't fix through talk therapy. And, like schizophrenia, it's
Yeah.
psychotic. It's
Mm-hmm.
hallucinations, it's delusions. Very much a neurotransmitter biological disorder that medication helps. Now, the counseling psychotherapy can help the quality of life of that person to become more positive. It can also prevent some of the stressors in the environment, educating the patient about, well, this is very stressful. And when that stress happens, it triggers more voices in your head. That's very important. They work hand in hand. But there's sometimes where the medication is absolutely paramount. It's the primary intervention. Another example is severe bipolar disorder. And it's a chemical imbalance, and a person gets manicky, and they're not going to listen to your advice as a therapist. So
Mm-hmm.
medication is hugely important with that. And let me just bring up a third entity, ADD and ADHD. You can learn a lot of coping skills like keeping lists and being organized and trying to think before you act or speak. But it is such a dopamine deficiency issue that if they would just take, a dose of Adderall or Ritalin within 30 minutes, they're phenomenally better. And if you had 100 people with ADD or ADHD lined up and you gave them Adderall, 90 of the 100, 90% treatment effect. That's how effective Adderall or a stimulant can be for ADD, ADHD. And, in like manner, it's important for the therapist to understand which of these mental health issues are really need medication from the get-go.
Mm-hmm.
We're really partners in this, aren't we?
We
Yeah,
are, yes.
we really are. That's so helpful. I can imagine a listener like hearing ADHD and wanting to learn a little bit more about it. Sometimes we do get clients within our that come into our office that's the thing that they're struggling with, or they don't even know that they have it, and so maybe they're being diagnosed with that later on in life. We see that a lot lately, or potentially it was labeled originally as anxiety, and now we're starting to see that there are some like ADHD symptoms underneath that. So I'm just curious, is there anything else you'd like to share with our audience about ADHD, what it is? And you mentioned the connection between ADHD and dopamine. So anything else that you potentially want to share? I find that to be very interesting.
Yes, it's, the stimulants are Schedule II medicines. They're in the same category as pain pills. Mm. So they're serious. They have addictive properties. So yet they have some of the highest effect of all the medications for other disorders. Adderall and Ritalin are more likely to provide help than, let's say, Prozac for depression. So people find out about suffering from ADD and ADHD. Sometimes they're a parent and their child is having problems in school, and they get on that Ritalin, and then they become a different person in school. The teachers stop complaining about them. And then that parent will look at their child and say, that's how I was as a kid. And by golly, I'm still like that as an adult. And then they come and see me. And basically, what I tell them is that taking Adderall for ADD and ADHD, it's not a life or death medicine. It's a quality of life medicine. So it allows them to be more focused at work, more productive. It allows them to be less reactive, less impulsive in doing their tasks. It allows them, it really helps the quality of their productivity and their interrelatedness with others, because they're willing to listen and not just blurt out and interrupt. But sometimes the person is doing quite well at work. That's not the issue. It's at home, and the wife is just sick and tired of, asking her husband. It's like, here's your honey-do list, and you never get any of it done. You're procrastinating and you're disorganized. Your closet's a mess. You leave the kitchen a mess. And then providing them Adderall, it helps them at home. Work is fine. It's just at home that they need it. So I have three children, and I'm married. And of the my three children, only 3 of them take Adderall. And they all have different flavors of ADD, ADHD.
Interesting.
My oldest daughter is never fidgety, but she was in the financial industry and looking at numbers and screens and having to put together these complicated proposals. And when she got on Adderall, she was able to get it done at a very, very high quality, very productive, very good quality work. And then the middle child, another daughter, if you sit next to her, her leg is always jiggling. But it's funny because when you're sitting next to her and her leg's jiggling and the table's shaking and the floor is shaking, and your thought is, I must be tremendously boring. Just super boring. Or oh my God, she's really in a hurry. So she takes Adderall and her leg stops jiggling and she's focused. But she says Adderall has an antidepressant effect for her. If she doesn't take Adderall, she's content laying in bed all day watching Netflix. Now that's a completely different flavor, And then my son, he's amazing because in fifth and sixth grade, my wife and we had to fight with him every day to do whatever homework he had to get done. And he was a mediocre student. And his 2 older sisters were like model citizens, straight A grades. And he wanted to be like them and go to, an elite private school. And it's funny because we referred him to a colleague of mine. He started taking Ritalin. The first day he took Ritalin was the last day that we ever had to ask him to finish homework. So it turned him around. He was motivated. He wanted to be successful. He didn't mind doing the work. And he graduated with a 4.2 from a college prep school. And then he went to college, very challenging college, and he had like a 3.7 GPA. So, you know, there's three different stories of ADD, ADHD. And the reason I tell them to patients is just there's ADD and ADHD, they wear so many different hats. They present in different ways. So, and some people need it for work or law school, you know, during the daytime. Other people, they need it for the evenings and weekends at home. You don't have to take the medicine every day, which is nice. It's not like an antidepressant that takes 2 to 4 weeks to kick in and do the work. The Ritalin and Adderall, they'll kick in 30 minutes. And it's interesting, you can give a person a test dose. As long as the dose is, you know, medium, high enough to make a difference, in 30 minutes, they're like, oh my God, I can't believe I have ADD, ADHD. I'm a different person. So,
wow.
And it'll work for several hours and then it'll wear off. Okay, hopefully so you can go to sleep at night. But some patients, I tell them, look, don't take it on weekends. Give your body a break on weekends because you do fine at home, or vice versa. You don't need to take it for your job. Take it on weekends so your wife's not going to wring your neck. It just depends. Or take it strategically. Take it, you know, at the end of the month when you have to do those monthly reports, you know, for your company or your boss, or before exams, you need to study. So it's a nice as needed medicine. It doesn't have to be taken every day. So, yeah.
Yeah, that's really helpful. As you were talking about your children and going over your middle child, it just reminded me the other day I was sitting with my nephew and he goes, "Do you have to go to the bathroom?" And I'm like, "What?" He's like, "Your leg is shaking," and I'm like, "No, but great observation." I love it. That's awesome.
Yeah.
So I have a thought, but I was wondering if you had a question, and then I'll follow up with something, Hannah, afterwards.
I was actually going to ask a little, like, because I've noticed in my mom, I've diagnosed her with ADHD. I know she has it. She will not do anything about it, but she's 58 years old, so she says, you know, I've made it this far. Why do I need medication now? But having a conversation with her, it's like 15 different topics, and you can't keep up, and it's just like squirrel, like all the time. So. And just the most wild thoughts you could, like, no one could ever think of, because it came out of nowhere. How would you go about convincing someone like that to try Adderall? Just like even on a test dose.
Oh, you know, that's a tough question, you know, and that's like patients' rights, you know.
Yeah.
Hey, I have a right to be a little bit off or a little bit crazy. That's my right. I mean, I've with friends and family, I've made suggestions of just try a dose, you know, just one dose. That's all you need, just to see. And oh my God, there's an extra Adderall tablet over here. But you know, it's I don't know. It's just like, you know, you lead the horse to water, and sometimes they're thirsty, and sometimes they're not. It just depends. And
yeah. It does keep it spicy. She's got something to talk about all the time, so it's very interesting.
Well, I will tell you that I think sometimes ADHD is adaptive in a positive way for people who have, you know, they have to juggle a lot of balls, and maybe they don't have to complete each one, but there's just a lot of things, and I think the ADHD helps them stay on top of it, you know, so there's an adaptive component to it. Just like depression, believe it or not, I think depression is a survival mechanism. I think depression is a way that your body tells you, hey, dude, you're not doing well. Your life and your environment is just destroying you. So I'm going to get depressed as your body, and you're going to stop functioning, and that's going to make you get help so you survive. I mean, it's an interesting thing.
Yeah.
Yeah.
Good luck with your mom.
Yeah.
Thank
I
you.
love that reframing. Sometimes I'll tell clients too, and they're struggling with something, I'll oftentimes reframe it in that sense where it might be a protective factor. It's a way that your body or your mind is trying to somehow protect itself, or like, for example, maybe dissociation might be an example of that. Or it's a way of just kind of surviving the way that it's used to surviving. And because sometimes we see some of these symptoms in such a negative light. But I think having a different perspective that could be a little bit more, helpful, I think, and oftentimes help people kind of work through some of their symptoms. I love hearing your story about your mom, Hannah, and then you talking, Dr. Griffith, about like leaving the little Adderall pill out for family members. I don't know. I can relate to that so much. I'm happy to hear that you have that same experience, Dr. Griffith, because sometimes as therapists, we'll have these side conversations, whether in consultation meetings or just personal, talks about how we see life through a different lens, and we're just kind of interacting with family members and friends and loved ones. And it's like, oh, like you would so benefit from counseling, or I think I know what may be going on, but I can't say it, because it's like they'll complain. And so I just wish that everyone, would really kind of take advantage of counseling. And I'm sure you probably feel very similar, Dr. Griffith, when you're around, family members or loved ones and you're like, oh, you would really benefit maybe from doing some kind of evaluation. What's going on here? It can be frustrating, definitely frustrating at times, but I love hearing that there's some commonalities there. After you asked your question, Hannah, it made me think of this. Sometimes there are clients that are a little bit hesitant to even talk about medication and the possibility of taking medication. Sometimes it's because it just seems like they have this idea, I don't want to put anything foreign into my body. You'll hear that, reason. Or maybe they've had a bad experience with medication in the past. And so it's really kind of traumatized them and they're like anti-medication now. And then you'll even hear reasons like, I've taken it before and I just feel like I lose myself, like I lose my personality. I feel like I'm just kind of zombie-like. What are some things that you would say to people that are kind of resistant to it, but we know that they would really benefit from it because they do show signs of what you were mentioning earlier, which are some of those more severe mental health diagnoses, and medication is really kind of the next step for them.
Yeah.
What would you suggest that providers, loved ones say to people who would really benefit from it, but they are resistant for whatever reason?
Gosh, sometimes I treat adults, and the toughest cases that I ever have are when I have an adult patient who is brought in by family members who give all this history and reporting of how crazy they are. Maybe they're manicky, maybe they're psychotic, maybe they're just off the charts angry and making everyone miserable. But the patient, him or herself, doesn't see it, denies it. And the family is left living with this person and dealing with all the radioactive fallout of that person's decisions and behaviors. But I'm helpless to do it, unless they're like dangerous, imminently dangerous to themselves and others, then I can Baker Act them, which is the worst thing to do. So then you get the, down the milder end of the spectrum where you just have the adult who would benefit from medication. But, it is a foreign substance in their body. So what I do is I just try to be a consultant to them. And I say, look, I'm seeing some symptoms here that you're describing to me that I think a low dose of a very benign medication could be helpful with if you want to try it. And I'm willing to do it. I'll even write the script for you. You can choose to fill it or not fill it, but this would be what I would suggest. And then we can meet in a month to talk about it, or you can call and set up an appointment to come back in a month. So I just respect people who take medicine or not. And you talked about people saying that it changes their personality. Well, the serotonin medications, Lexapro, Prozac, Paxil, Zoloft, Celexa, Luvox, they're great at helping with anxiety. I call them chill pills. So they help depression when a person is all anxious or agitated or irritable, and it chills them down. That's what serotonin does. But the problem with the serotonin system medications is that then they go and give negative feedback to the dopamine part of the mood circuitry. Dopamine is energy, motivation, giddy up, go, go, go. I enjoy things. I want to seek pleasure. So now people who are taking serotonin medications, it has changed their personality because they lack feelings. They're overly chilled and they're content sitting on the couch and not doing things. Their Aunt Mabel died last week. They want to cry, but they can't because serotonin enhancement has actually shut down that part of their emotions. So those are some of the nuances of prescribing these medicines that people live with as side effects, and it makes life not fun. Another example is Zoloft. It has that chill effect. I call it overchill. But Zoloft also binds to the gut. There's a sigma receptor in the gut, and it's kind of like an accelerator. So when that sigma receptor is being turned on, the gut goes faster. What that means is that people have multiple bowel movements daily. They have loose stools. And so people who take Zoloft, and they come and see me and I'll ask them, do you have frequent bowel movements? Do you have loose stools? Is it kind of like diarrhea? Yeah, I've had it for 7 years. When did you start Zoloft? 7 years ago. And I'll say, well, I can go to the same class that doesn't cause that side effect. And then they're much happier. The serotonin medications are chill and they cause overchill. And that includes shutting down sexual function, okay? Not fun. They tend to be somewhat weight neutral. Then over here on the dopamine side, that's the thrill pill. That's Wellbutrin. Wellbutrin is unique. It's the only norepinephrine dopamine reuptake inhibitor. So I call that the thrill pill. But the problem with Wellbutrin is that it gives negative feedback to serotonin, so it causes anti-chill.
Oh.
So where these people are too calm and too unemotional, these people, it can be rocket fuel. They're more anxious, they're more irritable, they feel tense. So anyway, you've got thrill causing anti-chill, and then norepinephrine is in the middle. And when you treat norepinephrine, it's more balanced. So it'll help dopamine and it'll help serotonin and not work against them. So there's some norepinephrine. But these are nuances. These are these are things that a psychopharmacologist should understand and know as a psychiatrist. However, unfortunately, many of them don't get all those nuances. Family doctors tend not to understand that. So any of that. So it's there's always a role for a psychopharmacologist.
Yeah. That's really interesting because I'm thinking of someone that I recently had a conversation with, and their provider was planning on putting them on Wellbutrin because also there is this additional benefit possibly of like weight loss or maybe appetite suppressant. But they asked them if they struggled with anxiety, and so now that all kind of makes more sense to me. But that shows you why coordination of care is so important. So really trying to get your providers to communicate and connect, and then also like as a patient, as a client, also important sharing your medical history and like other things that you might be struggling with. You might think, well, this provider doesn't necessarily need to know X, Y, and Z. Like let's say they're a mental health provider, they don't really need to know like medical conditions or physical symptoms, but really there's so much interconnectedness there. So that was really interesting to hear, actually. Yeah, I really appreciate that.
Yeah, so, when patients are like, I don't want to put any foreign substance in my body, it's like, I get it, So if we're going to do anything, let's just start off with a very low, mild dose. And you can take it, maybe even take it every other day. Like Lexapro, the therapeutic dose is 10 to 20 milligrams per day. I may start someone on 5 milligrams, and I'll say, just take half of the 5, or take 5 milligrams every other day, just as a test dose. See how your body does with it, and maybe develop some trust to work with them further if that's not going to be enough. And there's another thing. Sometimes a person doesn't have full-blown depression, so you can use teeny-weeny doses of like Lexapro. 5 milligrams, remember, it's a chill pill. Maybe it'll help tone down all that anxiety that they get every day. So they're not walking around with clinical depression, but they just worry. A low dose of Lexapro, subtherapeutic dose of Lexapro can help with that. So, there's some more other artful examples of psychopharmacology.
Wow.
Yeah, that's very helpful.
Yeah, and earlier when you mentioned like the dopamine to serotonin spectrum with norepinephrine in the middle, I was going to ask about that, but you answered that amazing. Like I never would have thought about how psychiatrists treat each disorder based on the three flavors of ice cream. So that's a very wonderful way to put that. So thank you for that.
Yeah, let me just throw something out for the listeners. I tell patients that if I were depressed and I had to take an antidepressant, I would I would take Wellbutrin, the thrill pill, starting because it's an amazing molecule. It's energizing, motivating. It helps. It's actually FDA approved for weight loss in combination with another medicine, but statistically, it's the only antidepressant that's associated with weight loss. Most of the, like everyone else is pretty much weight gaining to some extent, and Wellbutrin is weight losing. It can be used for ADD, ADHD because it has that dopamine effect enhancement, which is the same way that Ritalin and Adderall work for ADD, ADHD. It's helpful for smoking cessation. It was many, many years ago that there was a VA psychiatrist who was prescribing Wellbutrin to the veterans, and she saw many of the veterans were not smoking as much or not smoking at all. And she went to the drug manufacturer, which was Glaxo or Burroughs Wellcome at the time. She said, "Hey, I think this medication helps with people give up smoking." And they did a study, and sure enough, it got FDA approved for smoking cessation. You know, Wellbutrin is an amazing molecule. It has some scary aspects to it. Don't ever take more than 300 milligrams because at 300 milligrams, it's very safe in terms of triggering seizures, okay? Like 1 out of 1,000 people, which is low. But if you go up to 450 milligrams per day, that thrill effect of Wellbutrin, it's like thrilling, it's over-energizing the neurons. So now the seizure rate is 1 out of 250.
Wow.
So, you know, that's scary. That's 4 times greater. So, you know, a lot of the side effect issues with these medications are dose related. But anyway, I just want to throw out that Wellbutrin idea. And then I know one of the questions you had suggested to me earlier was what's on the forefront of psychopharmacology. So actually, there's a new medication called Auvelity, and instead of working directly on serotonin, norepinephrine, dopamine, it works on glutamate, which is the excitatory neurotransmitter in the brain. Glutamate in the brain is excitatory and it's ubiquitous. It's all over the brain in great high concentration. Then the inhibitory neurotransmitter, it's kind of yin and yang, is GABA. So Auvelity is a new antidepressant that works on glutamate, and it indirectly enhances serotonin, norepinephrine, and dopamine. But glutamate is a new mechanism of action for antidepressants. And then we have the transcranial magnetic stimulation, TMS, which I think is above all of medications. It's so effective, using magnetic pulses directed right about here to a very targeted small area of the brain. Very safe, it helps so many people with no side effects. And you go through 36 outpatient treatments, and then you kind of live happily ever after. So TMS is there. Then there's ketamine, but so ketamine provides twilight sedation, and it helps enhance serotonin, norepinephrine, and dopamine. It's been used in dental offices for twilight sedation, where you don't need an anesthesiologist because they're not knocked out, but they're kind of like unaware of the pain. So that can be used to treat depression. And then the pharmaceutical company, they divided the left-handed ketamine molecule from the right-handed ketamine molecule based upon how it bends polarized light. And they patented the left-handed one and called it Spravato, which is not an injection or IV, but it's a nasal, and that can treat depression. But the whole Spravato ketamine area, I'm not a huge fan of because I think TMS is so much better than ketamine and Spravato. And then within the antipsychotic market, there's a new medicine called Cobenfy, which is not working on the dopamine system. When people have too much dopamine, they get psychotic, like schizophrenia, or they can get manicky. And Cobenfy works on the muscarinic or anticholinergic system with minimal side effects. So that's kind of an exciting medication that's been introduced in psychiatry. So psychiatry has some stuff happening. I'm just glad that I provide TMS because I think it's the bomb.
Yeah, I love this, and I'm so glad that you shared with us originally on the first episode about TMS because ketamine is talked about, or there's been this trend over the last a few months at least where they would, I've seen a lot of information on ketamine, but TMS, I don't see as much out there on this. And so it was really great for you to provide that information to our listeners. That was really helpful. And today was so helpful. Hannah, I don't know if you do this. Sometimes if there's a client that I just know either we've plateaued or we've hit a wall, and I just feel like medication alone or medication therapy simultaneously is like the next best step. Oftentimes I'll present it this way. I'll say, you don't have to take the medication. You just make the appointment and attend the evaluation.
Yes. Yes.
And it's like, and at that point, you don't have to take it, or even accept the scripts, and you still don't have to take it. Get the medication filled, and you still don't have to take it. Like there's so many steps along the way that they can take that just can be harmless, and there's no reason to really have any like worry or stress related to it. And I think today's conversation is a good example of that, because there was just so much information, Dr. Griffith, that you provided today that I learned a lot. I'm sure, Hannah, you feel the same way.
For sure.
And I know our listeners will too. And this is just a good example of why it's important to just make an appointment, get in front of the doctor, and share what you're struggling with and see what their options are. And there's no harm in that, right? And you don't lose out on anything by doing that whatsoever. There's no cost to it. In fact, there might be some benefits afterwards, depending on the outcomes. Thank you so much for your time. I really appreciate it. This has been a great conversation. I'm sure our listeners are really going to be very grateful for this time that you've taken to be with us. And hopefully we'll see you again. So as always, keep reflecting.